From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
All right, welcome to episode 238 of the Crisis Jam. I am Laura Evans, and I'm going to be your host for this next hour. Thank you for joining us. We are going to be having a great featured presentation, a panel really from Kim Sanders and Matthew Holtsclaw. That's going to be moderated by Dr. Chuck about big feelings. Who hasn't had those in the real world? So make sure you let us know where you're from. Drop that in that chat, and let's get started. So if you were a part of our backstage pass, you got to see some sneak peeks, a little video, but let's start with our sound check. What fuels you in the morning? Who's having coffee? Who's having tea? Who's having something else? Energy drinks, we've got water. I need to have more water. I think I'm probably having lots of tea these days, but make sure that you bookmark crisisjam.com. That is the new website to see everything Crisis Jam, I'm sorry. And that is going to get you all of the items that we had before, including how to register, how to watch the live stream, signing up for the newsletter, watching past Crisis Jams. And then again, we have our various segments, the lead stories, feature presentations, news, pre-show videos, but you can always get those by joining us in the Backstage Pass. And we try to make it easy for you on YouTube. You can find all of the videos there. Make sure you like and subscribe so that you do not miss a video. And then they're also color-coded. You'll see those debates in neons. You'll have presentations, live in locations. We're going to turn it over to the news. And for this week, very interesting article, flip book that was available. And I'm actually going to pull in David Covington to explain a little bit of this one. David?
Hey, Laura. So for all of you in the Crisis Jam, we were thrilled to take you to Salt Lake City to visit the Kim and Carolyn Gardner Crisis Care Center. Building on the Arizona innovations and going next generation, a spectacular facility. We were at the NASBID conference in Washington, D.C., and I was at the table of a sponsor, Architecture Plus, and they had this coffee table style brag book setting out. And I flipped to the very first page, and it was a quote from Kevin Curtis from that Salt Lake City station. For too long, people in our community haven't known where to go if you're having a struggle. To have a place that is built on the idea of hope and dignity is exciting for us. And it showed a picture of that amazing Kim and Carolyn Gardner Crisis Care Center, which we took you to with Kevin and Rep. Steve Elison and David Huntsman and many more back in March. And we were there live and on the scene, and we toured all the way through the background, that amazing Zen garden that they have outside, the entire striking lobby. And then the second facility in that brag book was the Franklin County Crisis Care Center, which we also took you to in June. Eric Hipple and I rounded the building, and then Jonathan Thomas and Erica Clark and others showed us, the chief of police for Franklin County in Columbus, an amazing facility there. And so we thought, oh my gosh, two for two. But then the third page, I was not familiar with. This is the JPS Psychiatric Emergency Center, which Laura just opened 3 weeks ago in Austin, Texas. And there's a whole discussion of the design, which the Utah and Columbus were adult facilities. This is both a youth and adult, focused on law enforcement drop-off, next generation crisis receiving facility. And Laura, Karen Jones and I with the Crisis Jam have had an initial conversation with Zelia Baugh and some of the leadership team there. And we're at least exploring the idea, a little bit more challenging because they're already open. We missed our window to get in right before that, but we're exploring the opportunity to take all of you in the Crisis Jam to Austin in December, and we'll let you know how it goes. Laura, any reflections on what you've seen?
Well, those facilities look gorgeous. I actually have a question for you, David. Can you just briefly, like the importance of the aesthetic and design in helping crisis care feel like care? Like how important is that?
Yeah, so when we were in Columbus, we talked about so many of the elements were designed for the flow, the feel, and it's our topic today. How do we manage agitation, even aggression, people having big feelings? And we're trying to do that in a way that's safe for them, safe for us, and we can strengthen our ability by wide open spaces. There's innovations back. If you study this, Laura, over the course of time, starting in the 1800s, and multiple innovations since, people in Pennsylvania, people throughout the country, Mental Health America, have been focused on how do we strengthen the dignity and respect in these facilities so we can reduce the use of seclusion, restraint, forced medication, that kind of thing, with natural light, wide open spaces, engagement, but also thought of the flow itself. So we've tried to, as we've gone through these interviews, had discussions with Kevin Curtis and Jonathan Thomas about all that went into their thinking. And Laura, we've got a quick video from the pioneers at JPS about what they're hoping to accomplish with this new psychiatric emergency center in Austin.
Mental health has often been excluded from primary care, and one of the things that we know is mental health is part of total health, and not managing mental health can contribute to worsening of other medical conditions. So one of the focus of JPS over the last year was expanding our full continuum of care.
In our new psychiatric emergency center, we truly have designed this with the patient and family at the center, which is our true north at JPS. We really wanted to create something that's large enough, not only for now with the population of Tarrant County, but 15 years from now when our population continues to grow in Tarrant County. And in our ability to expand and build this new facility, we're able to see more patients and their families, and they don't have to navigate the hospital in order to find us. You literally can drive right up to the front door.
Patients are going to be introduced to a more broad, open concept of care with a lot of natural lighting, cool, comfortable colors, and less crowding to give them some more space to decompress. And we hope this will be a more calm, spacious, quiet environment for them to relax and center themselves.
Our psychiatric emergency center is often the first place. It is that first touch point. If someone has delayed seeking care, now there will be less of a stigma and easier access to receiving that first initial touch point.
If they don't need an inpatient admission, we're able to refer them to one of our 8 outpatient clinics where we offer a full array of services for child, adolescents, and adults, as well as other community referrals if the patient chooses. And so that's the benefit of coming here to the PEC, because it really can be a great access point to other services.
Awesome, David. Well, you got to make sure we get there, and we'll be in Fort Worth checking that out. So looking forward to that. Okay, guys. Well, now we are up for our hot seat. And what we like to call Who Wants to Win Crisis Jam Swag. Again, you can volunteer for this. Just reach out to the team by putting your information or reaching out via the chat. But for today on the hot seat, we have Tom Betlock and Paul Galdis. Tom and Paul, are you here?
I'm here, Laura.
All right, good to
Hi,
see
Laura.
you guys. Thank you for being in the hot seat. I hope you have your shirts already picked out. Again, you get the swag whether or not you get the question right.
No pressure then.
But no pressure. So today's question, Sydney Decker. So we saw part of that in the backstage pass. describes just culture in healthcare as a culture of trust and fairness, where we learn from failure rather than blaming indiscriminately. Which of the following is not one of his 3 central keys to judging accountability? Is it A, context, B, interpretation, C, outcome, or D, perspective? If you think you know, put it in the chat, but Tom and Paul, talk us through it.
All right, Paul, take it away.
It's interesting, Tom, right? I think we always say culture is so essential to our success. And what we're thinking, hold on, I can't actually see the question as that slid up, Laura. This trust and fairness are things that we always lean into. So now putting it in there, the culture of context, interpretation, outcome, and perspective is tricky. In a lot of ways, yes. It's all important, Tom.
I agree that they're all something that you'd want to look at in terms of being able to have trust and fairness. So is this where we can also ask the audience for their opinion and look for that in the chat?
You can. We've got Raj saying C. And again, this one's a little tricky because it's which one is not.
Right, exactly.
So we've got B. We've got a B. We should be seeing the poll results soon. Make sure that you, and it's split. We've got 51 saying C and 33 saying B.
What do you think, Paul?
It's funny, Tom. As much as those are probably the 2 that jump out as least likely to be on the list, I don't know how you build trust without getting interpretation and considering those things. So although the outcome follows, of course, it's the goal that we're all pursuing. I would think if I were thinking through which one does not fall on the list of central keys to judging accountability, outcome could be one of those. It's interesting.
Yeah, it just goes against my sense of like how you look at how performance is occurring, right? And so, but the audience said C. You're favoring C. I think we go with C. That's my vote.
It's a tricky one, Tom.
It's counterintuitive to me, but
yeah, we've overseen systems for a long time, and outcomes mattered a lot.
Right.
Well, I'm so glad you guys trusted the audience, and you get your swag regardless. But the correct answer is indeed C, outcome. We're going to hear a little bit from Sydney.
Great job.
Good job to all of you.
Yes, they steered you right.
At least 51% of them did.
Tom and I will spend the rest of the day evaluating outcomes and systems, though.
Right. Like I said, counterintuitive for sure.
Well, I think we're going to hear a little bit from Sydney at the Crisis Now 4 in 2018 of why it's
if you haven't had a patient
not outcome
by suicide, that means that you haven't seen enough patients. Emotionally, it felt like a punch in the gut.
When I look at Julie, and I know Julie, she would want to give the mother a big hug. That's what she wants to do. And cry. That's what she will want to do. And we've configured ourselves in institutional responses to this type of harm that make that fundamentally impossible. This is what I am passionate to change.
Yeah. How are people being caught doing things right, and how is that being propagated?
I'll let Joe answer that one.
We believe we're the only NHS trust in England who in their quality accounts have put staff-related objectives. And those staff-related objectives are about sharing at least 3 good stories every week with staff about positive things.
The time has come for this.
All right, the time has come. It's time to eat that cookie. So again, this is over under, where one person will guess a number, and then the next person, your partner, will say if it's higher or lower, over or under. So we've been talking about 911 dispatchers being classified as first responders. And so the question today is, how many states have passed legislation to recognize 911 dispatchers as protective service instead of clerical? So They've previously been considered clerical as a clerical job, and now pushed to be classified as first responders or protective service, the same way police, firefighters are. How many states have passed legislation?
I don't know if you want to do the over or pick the number. I know I tracked this legislation in Washington State, so they certainly were actively involved, but I think that's going to be the minority of states by a ways.
You think it's going to be what?
The minority.
Oh, Hannah put 7. Hannah put 7. That was exactly the number I was going to go with, Paul. So
All
I'll say
right.
7, and you're going to go over or under.
Wow, that's a low, tough number. I'm going to go just under. I would have guessed. It's really close, but I'll go under.
Yeah, I thought.
All right, we've got the audience saying C, going under. People are saying over. The actual number is 19. So
wow.
Oh, wow.
Well
over.
done.
That is much higher than I expected.
Yes,
That's
over
great.
quite a bit. So 19 states have recognized first 911 dispatchers as first responders. And there's actually federal legislation that just passed the Senate that would also classify 911 responders, dispatchers as first responders.
That's great to see.
Yes. Well, that takes us now to our lead story. And I'm very pleased to have joining us on a panel today, Matthew Holtsclaw, who is the Senior Director of Behavioral Health for Primary Health Network, as well as Kim Saunders, who is the Chief Operating Officer at Grafton Integrated Health. And this discussion will be moderated by Dr. Chuck Browning of RI. So Dr. Chuck, I'll turn it over to you.
Thanks, Laura. Hey, Kim. Hey, Matt. Looking forward to having this discussion today. You look at this title, Big Feelings in the Real World. And so today we're really going to be leaning into those big feelings, both ours and the people that we serve. And crisis care, we walk such a tightrope when you talk about the real piece of this. And it's this tightrope between protecting everyone's safety and creating dignity at the same time. So we're talking about moments where people potentially challenged with intoxication that affects their judgment or what happens, or challenged with mania that might be disturbing what they would normally do, or psychosis where they might have challenges of even feeling safe because of distortions that might be happening about their environment, past trauma that really impacts their expectations of how they're going to be treating and how they're going to be treated and their safety. So all these things are factors that can cause someone to potentially be violent in the moment, especially in safe places for help, in places where we serve people. And so we have this goal of making sure that we treat them with care and dignity, but we also have to keep them safe and our staff safe in doing that. And so today we're going to be talking about some really difficult, tough lines and tensions. And the goal isn't to have people in seclusion or restraint or handcuffs in a police car or in a locked emergency department bay, but it is to have care that's safe, trauma informed, and help us move that forward. And I couldn't be more excited to talk to people who I consider experts in how to do this well, and innovations. Both have led innovations and real evidence of outcomes that we talked about just in the past trivia question that shows that as well. So Matt, I'm going to kick it off with you and kind of say, in your experience as a leader and in nursing in crisis settings, what's the reality of acute risk look like day to day?
Yeah, if you're serving a community where you're accepting any patient, anytime, anywhere, it's a daily occurrence. The acuity can be high, and almost like that video. If you're treating and you haven't had a patient die by suicide, you haven't treated a lot of patients. If you haven't had one of these situations, you're probably not being a true crisis center. So the volume's out there. During my time at RI International, I led an initiative called RI Renew, where we took a renewed look at seclusion restraints, and we implemented SAMHSA's 6 core pillars to reduce seclusion restraint. And as we were doing it, one of my nurses actually left the organization. In their speaking with me, they said, if people are being evaluated because there's a safety concern, either a danger to self or others, how am I supposed to be safe if we don't use seclusion restraint? And I'm glad to report after we rolled out RI Renew, patient injuries went down, staff injuries went down. Basically, every outcome improved. HR metrics improved, retention went up, staff satisfaction went up. So I wish that nurse the best wherever he is today. But this is a very important topic, and we actually are safer when we really lean into these things.
So technically, and I think this is one of the things that we always talk about, but your sense then is that our leaning into the skills actually decrease the use of seclusion and restraint because of confidence. Can you talk a little bit about that and some of the things that you practically went into the training and those things?
Yeah, exactly. A lot of organizations, they have hands-on trainings and it's an annual requirement. And so people get a new employee orientation and then they get it annually thereafter. And that's just not enough, right? In UCRU, we learned that learning happens when something is repeated, powerful, or reinforced. So we have to repeat these skills more than just annually. And so we did massive retraining for all staffs, but it wasn't just a one-time thing. We had workshops and we had monthly reviews and constant debriefing of events. So really, training was not a one-time thing. It was an ongoing process. And as we saw, the higher trained our staff were, the more confident in our staff's ability to maintain safety, the less likely they were to actually use seclusion restraint because they had other tools available to them.
Thanks, Matt. So speaking of other tools, that leads to a great segue into introducing Kim and talking a little bit about UCRU. Could you just maybe, I know you've talked and used that term in your training about comfort versus control. Can you talk a little bit about that? Introduce us to that concept. I know you've been on previous crisis jams, but how does it fit into this topic of today?
Yeah, absolutely. So yeah, it was the same for us here at Grafton. We needed to give our staff more tools. And number one, we did know that we needed to give them a physical alternative to restraint and seclusion, sort of be there before you get to that point. But then we were like, we want to do some other things too, right? A physical alternative helps us to keep safe and it helps us to be confident. But what about before we're feeling unsafe? And so this idea of comfort versus control came about. And honestly, it came about with us all looking at ourselves and thinking, like, when we have bad days, we all know what we need to help us. Everybody on this call, you can say, you know, a walk, a bubble bath, a glass of wine, like, you know, things that help you. But when we really looked at the children and the adults that we were serving, we weren't offering them those types of things. Now, I promise we're not handing out wine, but we weren't offering those types of things. And that's how that all came about. So when someone's at their worst, how can I be at my best and offer people just some of the very simple, typical things that help us all get back and self-regulate. And so, you know, it works. Sometimes it's the simple things that work.
They are. So this is a question to both of you. So when you start thinking about this topic, I think you can break it into different categories. So in managing this, two that y'all have just brought up are preparation and prevention. So it's the preparation, thinking about the environment that you have and those types of things, and then and training your staff and getting them ready so that they feel confident. Can you, Matt, maybe go into any other details, things about environment, things about other alternatives that help protect and prevent up to the point of imminent danger?
Yeah, that's a great one. Really embedding trauma-informed care into your culture. And trauma-informed care is not just the actual care people receive, but it's the environment, it's the lighting, it's the spacing of the facility and the architect, as we learned a little bit earlier. All those things absolutely matter. Even little things like proxemics, which is your bubble, right? And our bubbles all got a little bigger during COVID. But being aware of your bubble, and when somebody's having big feelings, their bubble gets a lot bigger. And so making sure that you're respecting that bubble and asking permission to enter. Little things like that can make a big difference in preventing seclusion restraints.
Kim, your thoughts? Y'all have such a great lens into the trauma-informed care. I felt when doing the training, it helped explain things at such an easy to understand level, maybe more than any other thing I've taken part in. So thoughts on that?
Yeah, absolutely. And I would just add, that we're talking about like the practice that increases not only the competency, but the confidence. And so often people think we need to practice the physical stuff. But we also need to practice, that the trauma-informed approaches. So like, I've already heard people mention debriefing. So when you're looking at a debriefing, how do we create those situations so they are about learning, that they're not about blaming or trying to hold someone accountable for something that maybe went wrong? But then how can we understand what we need to practice over and over and over? When I think of a first responder, I have some friends who are volunteer firefighters. They practice a lot, right? They are setting things on fire and practicing. Why aren't we doing that more with things that we know are comforting and things that are proactively sort of like before we even get to the point of needing to de-escalate things? But again, I think we have to have that just culture so people feel comfortable in identifying maybe what we could have done a little bit different, knowing that they're safe from the blame and the shame piece.
So now you're bringing up the other two kind of P's. We've talked about prevention and preparation, but maybe in protection during an actual event. How can we limit the amount of time that something is going on as we're keeping that person and the other people around them safe? And those are those things about, can you use pads as an alternative, for example? Are there other options that still work to keep safe that don't involve putting hands on someone? But if we do put hands on someone, how can we make that super time limited safe? And those kinds of things. And then the other piece you brought up is with the just culture goes into this last piece, is like the post review. Like, what do we do afterwards to support our staff and support that person that went through something very traumatic? Any comments for either one of you on those pieces?
Well, I think my first thought is when I hear you say that, I think sometimes it becomes overwhelming in our systems. When do we have time to do that? I think that it's about having a different lens on that. When we can't waste time and not do it, right? Because if we can all find some minutes in a day. And if we take the time to do that with a purpose of being supportive of employees and the people who went through this, the gain is so real and big that it's worth it. It's worth it not only for those that we're helping, but it's also worth it for our employees.
Yeah, I think David mentioned in the chat, and it goes along with what we were just talking about in that trivia question for the 911 responders. Is this? I mean, when you start talking about this is really hard, difficult, challenging work, and it is putting yourself in a line of danger. Not every day and not every moment, but and that's why the training and these things are important. But we really have to have things in place to help our staff feel confident and safe, so they can be trauma informed themselves to do their best at creating a caring atmosphere. Matt, any thoughts on some of the things that you've figured out over the years in terms of the amount of drilling to be good at using the UCRU techniques, or to be good at using seclusion restraint techniques if they have to be used, so to do it correctly?
Yeah, someone in the chat put that practice builds that muscle memory. And I mean, in simple skills like just backing up, giving someone space. I mean, when was the last time you shuffled backwards kind of quickly? Right? It's not a skill that we typically use in our everyday lives. And so if you're going to work in a crisis facility, that's a skill you need to have. And so you need to practice it so you have that muscle memory. And so it does take a lot of hours, and annual training is not enough. It takes more hours than that. And so especially if it's a new skill for somebody altogether. I do want to go back briefly to that just culture and to mention a little bit about debriefing, because that's one of the 6 pillars and something we leaned into a lot at my time at RI. And at first, that was really difficult for staff. They didn't trust us. Right? When we say this is a non-punitive process, we are doing this. It's a just culture. We're not looking to blame anybody. We're looking for what we did well and what we could do better. And at first, they were very tentative. And we strive to do 100% video review of all events with our staff who were involved in them, so they could learn and we could take those learnings to future patients. And at first, like I said, it took time, but over a while, as they gained to trust and we really embedded that just culture in the organization, they really looked forward to those reviews and they looked to see what they did well. And they looked to see, oh, right here, I think you could have done this better. And I didn't even have to say anything. It was the staff helping the staff get better. And so when you really lean into that just culture and those post-event debriefings, that's where a lot of progress can be made.
Agreed. A great quote from Kevin Curtis out of Utah, crisis jammer for, where he basically said, and it's a really good point, if you don't spend time debriefing, learning, supporting, training, and staff, and improving your practice, you'll spend it doing restraints, seclusions, and post-seclusion paperwork and meetings and quality improvement things that go along with that. And he said you pay for it either way. I think that's a great quote. And that's one reason to do it. And the most important reason to do it is to create an experience that has both dignity and safety for the people doing the work and the people that we're serving. Kim, any of your thoughts on a particular story or a particular incident that would help the learning community think about ways to help foster this system for their staffs?
Yeah, I think the other piece of it that just keeps, as I'm listening, it keeps coming to mind is we also need to make sure that we are providing all of these tools in order to sustain the workforce, right? I think we could all agree that there are times that these jobs, just like a first responder job, is very tough. It's, in some cases, it can be risky. And as we give people more and more tools, I would say another tool in the toolbox that as a society is to give people some grace, right? We're people working with people. And if we all sort of, again, lean into that and encourage us to take care of each other, everyone, that sometimes that means that sometimes with the best intentions, a good old fashioned accident or mistake might happen. But as long as that is with the best intentions, what can we learn from it so we can keep getting better? Because I think that we need to do that in order to sustain a workforce that really wants to honor people by doing this work. Because it scares me. If people don't do this work, then what are we going to do?
Yeah, nobody gets into the workforce because they want to use seclusion and restraint, right? They get into the workforce because they want to help people. And if they did have to use one of those techniques, it's because they perceived a danger, right, to self or others. And so to maintain safety, they use one of those techniques. And so really making sure that that just culture is in place, because that person from their perception felt unsafe when they used that skill. And so if we come at it from a punitive lens, it's going to drive them away. And then like him said, there won't be a workforce left. And so really just culture, looking at it as an opportunity to learn, grow, develop the workforce leads to better outcomes. And like I mentioned at the very beginning, the outcomes are better for everybody, patients, staff, across the board. All metrics go up when you put these practices in place.
Yeah, and I don't think we should, and none of us on here, I'm sure none of the 200 and some people on here want to confuse that with things that are not done with the best intentions, right? We need to have zero tolerance for things that are abusive, neglectful, like they cannot be tolerated. Again, what we're talking about are things where good people are trying to do good work and make honest mistakes. That's where the grace comes in for us.
Yeah. Such valuable things. I'm going to put both of you on the spot and kind of get a question that's outside of the facility side, but what are ways that the rest of the crisis continuum can help in the preparedness, the prevention, protecting the overall system? Any thoughts on things that you know works that could be applicable lessons to the rest of the continuum?
Yeah. In crisis centers, at least a high percentage of these events occur within the first few hours of that person being there. And so those are the hours where they're engaging with just after they engage with those other systems, the mobile crisis or the dispatchers. And so I would highly implement those trauma-informed care practices across the board.
Yeah, I love Matt, when you say that across the board, because again, it's also trauma-informed practices for the employees, right? I mean, sometimes when we're teaching new care, we're constantly trying to remind people that this is not just how we want an employee to treat a guest or a patient or a child, that it's got to be how we treat each other, right? For it, again, to sustain and to sink in, it's got to be what we do for everyone.
Yeah, I give a training where I compare just culture and trauma-informed care, and they're very, very similar.
Yeah. Really good concept. So I think our time is kind of nearing to a close, and I so appreciate y'all helping us walk this tightrope and think about the lanes of both sides. Any closing thoughts from either you, Matthew, or Kim, that you want to leave the learning community that we didn't cover? Anything to wrap up this in a bow?
Yeah, I just say it's possible. This isn't a pipe dream. It's doable, and Kim Ukuru has some of the tools to do it.
Yeah, I'm with Matt. It's just there's hope, right? It's a tightrope, but we got this.
Thank you so much.
All right. Well, thank you, Dr. Chuck, Kim, and Matthew. What a great discussion. And I love those themes there, right? Safety, care with dignity and respect and grace. So I'm going to bring in our roundtable to get their reflections. For today's roundtable, we have Dr. Robert Eilers, who's the medical director at New Jersey's Division of Mental Health and Addiction Services, as well as Tanja Miles, who is an author, a veteran, and the founder of Set Free Indeed Ministries. Dr. Eilers, I'm going to go to you first. Share your reflections with us.
Thank you. Well, it's a very good discussion. A lot of the points hit home with me. I will say most of my experience in this area was initially as a state psychiatric hospital medical director, where we had a big initiative to reduce seclusion and restraint in our facilities. And that was a time in the early 2000s when Nashbit and others were doing a lot of training and promoting the 6 core principles. And, it's funny, they're still important today. They are the basis of a lot of what we're talking about. And I think it basically, though, it was a culture change in our facilities, a leadership directed, but very staff involved from all levels to get buy-in, including especially our direct care staff. We introduced peers. We spent a lot of time training. We did the debriefing, as was mentioned, was very critical because training is only going to give you the basics, but you need to talk in real terms what you're doing right or wrong, or what you could do better, not necessarily wrong, but what you could do better in actual situations, with our patients. So that was a successful effort. Trauma-informed care, as Kim talked about, embedding that was critical. And I want to give a shout out to Dr. Joan Galise and Raul Almazar from Nashbit, who really helped our facilities at that time and since that time on that kind of issue. So today, I'm very much involved now as the medical director at our Division of Mental Health and Addiction Services in New Jersey with trying to implement these kinds of practices in our community crisis system, where with 988, with our new services that are coming on, we want to make sure that we're following all of these practices, that we're providing trauma-informed care, safety, comfort, and really both for staff and for those we're serving, because as we know, it is a difficult environment. Sometimes we hear about workplace violence. We know it is a factor, and so we have to put a lot of emphasis on this, not only because it's the right thing to do, it's necessary for our patients, but it's also necessary for our staff and to maintain our staff, which is a big issue right now. So I think paying a lot of attention to the environment, as was our start to discussion here, with facilities that promote safety and comfort, And, it was hard when we had the state hospitals because we didn't have environments like that. But we brought in, we developed comfort rooms, we developed comfort carts, we found alternatives. And I guess we have to do some of that today in our community environments. Today, we have crisis screening centers that are really connected with, typically with emergency rooms that have been the center of our crisis system. We are moving now towards new programs according to the SAMHSA principles. We have the crisis receiving and stabilization centers, and they are going to provide more of what we're talking about today, trauma-informed care, and also hopefully best practice protocols to manage agitation, aggression, and really support the staff in this role. So we're early on in that process, but I think the environment is important. We know, and I think it's, many people go to emergency rooms or waiting rooms, and they're very loud, they're noises, they're overstimulating. We have to pay attention to those kind of things. We have to pay attention to the interactions that occur prior to the emergency or when the person is admitted, and they're asked a lot of questions and really almost forced to, because that's the usual protocol. We need to consider right from the very start how their, what their needs are. Someone once said, I don't know who said it, but you first, when you speak to someone, you give information and then you give instructions. And that's what we need to do. We need to assess, I think, people and where they're at and what their needs are. We're continuing to promote peer services, which are so important. In our system, that has made a huge culture change. Not only are peers good for the clients, but I think with the staff who are learning from peers about the way they need to interact to appreciate, respect the person, validate their needs.
Dr. Eilers, I think that's such a good point, particularly with peers and that experience. Tanja, you've had a lot of experience in that. What is your kind of reflection here from the presentation and what Dr. Eilers just mentioned?
So Dr. Eiler and Kim and Matthew are the truth. Let me just say that. And so as everybody was talking, I was just thinking of, every situation I have been in, and I've been in different situations according to what year was in my life. For example, when we had our treatment facility, I remember we were all not trained for real. And I'll never forget when, I put hands on a client one time because the client was being violent to me. And I never forget when I put my hands on that, it was one of our adolescents. And I'm like, I am going to jail today. And so instead of me grabbing, I did grab him and I just hugged him. I'm like, okay, whew. After that, we did get some training. So training is key. And so when we're talking about people having big feelings, we have to have, we have to have open spaces, which, is the surroundings, the aesthetics, the trauma-informed approach like we're talking about. We have to have open minds. That comes with training and tools and skills. And look, I'm a military girl as well, military police. And you're right what Kim said. We have to, we always train the same thing. We know crisis is going to happen. We know things are going to happen, but it should be, muscle memory. How do we do it, just in case it happened and it comes second nature? That's training. And the other thing is open grace. We have to have open grace. We can't go in, we know we're going to go in knowing that it could be some threat, but we cannot go in with preconceived notions. We definitely cannot go in with profiling people. And so, that open space, open mind, open grace is key. And one size does not fit all. Again, and look, and I've been on both sides. I've been where, being a treatment provider, being a peer support specialist, engaging in clients when they were, a harm, to themselves really and to others. But then, go because I'm trained better, it's better for me, it's better for them. But I've also been that client, where I was restrained. I think the first time I went to mental hospital, with a hospital, I was restrained, and they said it was for my own good, and so I know how that feels. But I also know that trauma also took me back to the trauma of being restrained when I was being molested as a kid. And so I think, again, open space, open minded, open grace, and everybody has talked about that. And the more training, the more tools. It's not just comfortable for us, as the person who's, serving and engaging, but gonna make it more comfortable for the guest as well. And look, the aesthetics is huge. We talked about that at first. And, from Baton Rouge, Bridge Center for Hope, to the Crisis Care Center in Salt Lake City, Utah, we're changing the game, and the place that you guys even mentioned when we came on. So, we have to have more training, more space, more grace, and all of that good stuff, because we all need to be there for our clients and for each other.
Yes, thank you so much, Dr. Eilers and Tanja, for that. I'm going to give probably about 30 seconds because I think that quote really resonated, that comment in the chat around we pay for this either way. So Kevin Curtis, if you're available, please come off mute and we can spotlight your camera just to kind of elaborate for that really briefly for us. We have about 30 seconds.
Sure. Yeah. Like I think really all of this comes back to, we're talking about environment here. Environment is a function of aesthetics. Design is not just about how a thing looks, it's how it works. Steve Jobs taught us that, right? And so when I think about how we create environments, it really is about how we make people feel. And so a lot of our approach has been really focused around helping people understand, regardless of what your role is in crisis care, the intervention is care. It's not a therapeutic technique. It's not a medication. It's not your evaluation or assessment. You are here to focus on how to make a person feel better and how to provide care to people. Your training are tools and tactics that you use towards the end of helping a person feel cared for. So we use all of these tools not as means to an end, but as a process of how do we make a person, how do we help a person and lay the foundation for a person to feel better. That caring is the intervention. Everything else are just tools and tactics.
Yes. Thank you so much for putting a bow on that, Kevin. And I love what you said. We pay for it either way. And I think that goes for whether it is paying for it in an emergency room or paying for it in a place where they can get care. Again, making sure people get the care that they need, and it comes with dignity, respect, grace. I love this conversation. Thank you so much. We're going to move forward to the briefing room. And unfortunately, our colleagues at SAMHSA are not able to join us. As we know, the government is shut down. For those who may be wondering, 988 Suicide and Crisis Lifeline, even though it is a government program, is still up and running, available 24/7. So we will hope that they can join us next week. With that, we are going to move forward, and I believe we have Christy Malik from Nashville giving us the update today. Christy.
Thanks, Laura. It's always great to see your warm smile and seeing you host today's Crisis Jam. So, and it was also great to see so many fellow Crisis Jammers at last week's Crisis Con. And again, I just really want to thank, for us having this space. As Tanya said, that open space. And as we're kind of talking about, restraints, and seclusion, I just want to, also kind of talk about also the impact of chemical restraint. So when we're looking at policies and things like that, also keep that into consideration. I think it really goes back to what Kevin Curtis said, is how to make people feel better. So I just kind of want to kind of say that first before I give the Nashville update. So if we can go to the next slide, please. Thanks. So I just want to highlight that we have updated our 988 fee FAQ, and it reflects 13 states that have passed a 988 fee. So again, kudos to those 13 states. And we're really hoping that our revised FAQ will kind of help more states as they're having those discussions with policy decision makers and advocates to really help move the needle in getting more states to pass a 988 fee with the upcoming January legislative session for many states that occur. So you know, again, this two-page FAQ really just kind of highlights why we need a 988 fee in addition to other 988 funding streams, and also the oversight of those 988 fees. And then again, we highlight some state strategies that worked for states that have passed a 988 fee. Excuse me. And so we are really wanting feedback from you all. So from this jamming community of anything that we should revise for the 988 fee FAQ for future iterations. So again, we just really would appreciate your feedback and suggestions. We just want to make sure that this document is helping meet the needs of the crisis jammers. So on that note, I'll turn it back to you, Laura.
Thank you, Christy. So good to see you. And thank you for all of that work. So important. Thank you to all the advocates, champions who continue to pound the pavement and get those fees and appropriations in place. So I'm going to turn it over to Samira from NAMI and Daniel Heron from Vibrant for our state heat map.
Hi, thanks, Laura. Hi, everyone. My name is Samira, and I am the Senior Manager of State Legislative Analysis at NAMI National. I have two updates for you all. First, Massachusetts has a student ID bill, SB 1384. This was introduced back in February, but it adds 988 to the student ID for grades 6 through 12. This passed favorably in the first committee and was referred to the Ways and Means Committee September 11th. And then my second update is DC's Committee on Health put out a budget report that recommends that the district explore a 988 fee using the same model and fee rate as 911. And that is 76 cents, 13, which would bring in about 13 million. This is just a recommendation, but wanted to flag this report for you all, and we'll be keeping our eye out if anything comes from it. And I will turn it to Daniel.
Great. Thank you, Samira. And hi, everybody. Daniel Heron, Manager of State Policy with Vibrant Emotional Health. Just a couple more things to flag. In Wisconsin, we're tracking AB SB 309, which is a 988 911 liability bill. The bill provides civil immunity to PSAPs and 911 dispatchers in Wisconsin who are transferring callers to the 988 lifeline, and it shields them from liability for the outcome of the call. It only applies, or rather, it doesn't apply if the injury results from gross negligence or willful misconduct. So it's really only when they're acting in good faith, which we know almost all of our PSAPs are. There are two versions of the bill. There's one in the Senate and one in the Assembly. The Senate version has passed out of committee and is pending a floor vote, and the one in the Assembly is before the Rules Committee. Also want to flag that in Colorado, Colorado has had a 988 fee for a few years now, and it was set at 18 cents. Back in August, the Colorado 988 Crisis Hotline Enterprise, which is the formal structure, formal organization that's tasked with funding 988 in Colorado, and they set the fee amount. Well, they voted to raise the 988 fee to 30 cents. And the 30 cents is the cap that's set by the state's legislation. So in the future, if the state wants to increase that amount, they'll have to go back to the legislature. But it is really good to hear that Colorado is getting an increase in funding in 2026. And with that, I will pass it back to you, Laura.
Okay, thank you so much, Daniel and Stephanie. I'm actually going to turn it over to Kristen to give us an encore.
Thank you so much, Laura. Before we look ahead, I definitely want to have a huge shout out to our headliner sponsor, Advocates for Human Potential. We're building a diverse lineup of partners who are going to represent the full spectrum of behavioral health, and AHP is leading the way. But before, again, we look ahead, I'd love to welcome Susan from AHP because she's here with us. Susan, do you want to come say hello? Introduce yourself.
Sure. Thank you so much for having us. I'm really excited to hear the conversation today and looking forward to some further conversations about workforce. You know, today's conversation really made me think about the way that we frame workforce around behavioral health at AHP. I oversee our Workforce Innovation Lab, and we ground our work in three main buckets: healthy systems, healthy organizations, and healthy employees. And so thinking about giving grace to folks who were doing the direct work really resonated with me, and thinking about giving grace to the employees and centering them in the work that they're doing every day. So
I couldn't agree more, Susan.
Conversation.
Yeah, I'm very much looking forward to the segments that AHP is going to offer about workforce so we can share more with our learning community. And extra thank you for being one of our headliner sponsors. Thanks for saying hello. Is this your first jam, by the way?
It is.
Oh, that's so exciting. Welcome, welcome, welcome. And welcome to any of you who this is also your first jam, and invite your friends. You want everyone to have their first and ongoing jams every single week at 12 noon Eastern. Any other comments, Susan?
Not right now. Thank you.
Okay, sounds good. Thank you for joining us. In addition to AHP, we do have another headliner sponsor that we will be announcing soon. And we also have some other sponsors that we're finalizing the last minute things to get that before we can announce all of them. But again, like Susan said, like Laura said, like many have said, today has been a great episode. Huge thanks to Kim, to Matt, to Dr. Chuck for sharing those powerful insights today. Every conversation like this does remind us, if we're going to really accept people in crisis, including those under the influence, high acuity, folks that maybe a lot of the other systems have rejected over time, then safety, dignity, and respect for everyone, our guests, our staff, has to be a non-negotiable. I really felt passionate about today's conversation as somebody who used to work in operations for Recovery Innovations, that we have to accept everybody. And when we accept everybody, we treat everybody with dignity and respect that they all deserve, because everybody also deserves recovery too. Again, thanks to AHP for being our headliner. Okay, so next week we have we love our fireside chats here. We have a lot going on in the last month with fireside chats, but next week we are welcoming Dr. Rochelle Head-Dunham, and it's going to be moderated by Joy Brunson and Sumbaga from Recovery Innovations. Dr. Rochelle Head-Dunham is going to be talking about what they don't teach you in addiction psychiatry. I'm actually really intrigued by this topic. I want to know what they don't teach you in school. I know what they didn't teach me in school when I got my master's in MFT, but I'm really curious what they don't teach our MDs in school, and what you have to learn kind of on the fly, or what you learn in your actual practicum. And then in 2 weeks from now, we're going to have Dr. Kelly Posner-Gerstenhaber, who's going to join us to discuss how the Columbia protocols are reshaping crisis care from screening to safety. I know we use the Columbia regularly in our services, and I imagine a lot of you do as well. We're really excited to focus more and more on all kinds of protocols, all kinds of substance use, other areas that maybe we've missed in previous seasons. Season 6 is hopefully going to be one of our most dynamic. Thank you again to Paul and Tom for joining us in the hot seat. I really like this team aspect that we've added this season. I don't know how you all feel. If you want to get some swag yourself, go ahead and make sure to email us so that way we can help you get in the hot seat with a partner, and you can get some of those cool tees and hats that we've got on the website. And then also, Laura, as always, our hostess with the mostest. You did a fabulous job. We definitely want to thank all of our audience for watching, our ASL interpreters, and our behind the scenes crew for everything that happens to make this show go on every single week. So again, thanks for watching. We want you to tune in, log on, join the movement, and we will see you next week.